Good morning. Welcome to Public Health Grand Rounds. This morning it's my pleasure to welcome Dr. Susan Weinstein, who is our state public health veterinarian. She joined the department in 2005, having worked in private practice for about 30 years. Since joining the department, she's done excellent work. She's a member of a number of committees and councils, both in the state and nationally. She's received a number of honors. She's a member of Public Health Honor Society and got the Director's Award for Science in 2014. She's a graduate of Cornell, both undergraduate and her veterinary school. And we're very lucky to have Dr. Weinstein in the health department, not because of the excellent work that she does, important as that is, but also because she is a wonderful person, and I enjoy interacting with her every time we do. So very happy to have her both at the health department and presenting today on the topic of, do we have Lyme disease in Arkansas, which is a very hotly debated topic, and we're all anxious to hear what she says.
Well, thank you very much, Navar. It is a pleasure to be here, and hopefully we can address some of the concerns about Lyme disease. And I wore lime green, so we want to keep it a little light. So here's our learning objectives. We're going to cover a little bit about the symptoms, the epidemiology, how to diagnose it, which is the important key part, and ticks and tick ecology, and try and answer the question of, do we have Lyme disease here? So Lyme disease is caused by a spirochete bacteria called Borrelia burgdorferi and a newly discovered Borrelia mayonii. It's carried by the Ixodes ticks, and clinically it shows up as a fever, headache, fatigue, muscle aches. Often there's what's called an erythema migrans rash or a bullseye rash, and then it can go on and become a disseminated disease with some chronic symptoms. So the early signs within 3 to 30 days are the fever, chills, headache, fatigue, stiff neck, a lot of just ain't doing right syndrome. Could have swollen lymph nodes. Sometimes these symptoms come and go. The erythema migrans rash only occurs in maybe 60 to 80% of people with Lyme. So we can't rule out Lyme if no one saw that rash. This is a skin lesion that typically begins as a red macule, red spot, or papular raised bump, and then expands over days to weeks to form a large round lesion, often reaching maybe 10, 12 inches across, and generally it begins to clear in the center, and so you see a more of a bullseye kind of appearance to it. This rash does not appear immediately after a tick bite. If you see a red lesion associated with a tick bite right away, that's a hypersensitivity. That's just a reaction to the bite. True erythema migrans can feel warm, but it really isn't itchy or painful. Usually clears as it gets bigger, and it can be on any part of the body. It's usually along with other acute symptoms. And the diagnosis of EM has to be made by a physician. So here's some pictures of some very typical EM rashes, and you can see how large they are. They don't all look exactly alike, and then the one on the far right shows multiple lesions. The more chronic symptoms, the ones that occur later, days to months really after the tick bite are of great concern to our citizens. There are severe headaches and neck stiffness, arthritis, especially with severe joint pain and swelling, especially in many of our larger joints. There can be a facial palsy or a drop on one or both sides of the face, and intermittent pain. Also can affect the heart. There can be episodes of dizziness, shortness of breath, inflammation, nerve pain, and many people describe a short-term memory loss or a brain fog, as it's called. Now, there's another disease out there called STARI, Southern Tick-Associated Rash Illness. It does create the same kind of bullseye rash as Lyme. It follows the bite of a different tick, the Lone Star tick, and does the same thing of expanding, becomes quite large, and it can be accompanied by fatigue, fever, headache. But unlike Lyme, STARI doesn't have the long-term chronic symptoms. This is a photograph of Lyme. I want to thank Dr. Haslow. This is a picture of his daughter. And she got a red expanding rash with central clearing. This was probably STARI. We don't know the cause of STARI. It's not caused by Borrelia burgdorferi. At one time, they thought they had identified a Borrelia lone stari as the cause, but then that has never been upheld, so now they don't think there is a Borrelia lone stari. But this rash cleared up with antibiotics, no long-term consequences. However, it may clear up even without the antibiotics. We don't really know. So where is Lyme found? It's focal in its distribution, as you can see on this map. In 2015, 95 to 96% of the cases of Lyme occurred in the same 14 states. You can see that it's clustered up in the northeast and spreading down a little bit down the eastern coast and in the upper Midwest. Verified cases from other states are often associated with travel to a Lyme endemic area. There's exceptions on the West Coast where they have Ixodes pacificus, a different Ixodes tick, and that's where some of those California cases come in. So here's the distribution of the tick that carries Lyme. And you can see that, again, it's in the upper Midwest, the Northeast, but this same tick, Ixodes scapularis, occurs in the Southeast and all the way over to the middle of the country. It's a very abundant tick, but their questing or host-seeking behavior appears to be different in the South. However, we have a lot of tick-borne disease in Arkansas, including Rocky Mountain spotted fever, or the spotted fever rickettsiosis, ehrlichiosis, and tularemia. These are transmitted by ticks other than the Ixodes tick, and as well, a lot of them, such as Amblyomma americana, which is the Lone Star tick, are larger ticks and more easily noticed. So we are a hotbed for tick-borne disease, as you can see in these maps. Disease reporting in Arkansas is centralized. We're a centralized health department. We get reports, laboratory reports, from multiple sources, from providers, from hospital laboratories, from commercial and reference labs. And reporting is either electronic or faxed in, paper-based. For tick-borne diseases, providers and labs often will submit everything to ADH, including the negative reports. From 2011 to 2016, we received over 11,000 reports of tick-borne illnesses. Approximately half of those turned out to be cases of either confirmed or probable. But these include anaplasmosis, Ehrlichia, Rocky Mountain spotted fever, tularemia, and this is a significant burden for our department to investigate all of these lab reports. Reports of Lyme are collected and verified by state and health departments all over the country. We follow a case definition that is under the auspices of the Council of State and Territorial Epidemiologists, or CSTE. And we use different, that case definition has changed over the years, so it isn't the exact same definition that it once was. Then we report to CDC on our confirmed and probable cases. So we have to use a uniform system for identifying cases, this case definition, so that we can compare apples to apples nationwide instead of trying to compare and come up with our own case definition. So we are reporting Lyme cases for surveillance. This is not necessarily the same as a clinical diagnosis. Surveillance is just fits the case definition, but we shouldn't use this for clinical diagnosis or determining the standard of care for any particular individual. We set guidelines for quality assurance and it shouldn't be used for providing standards for reimbursement. So we're merely doing surveillance, but not clinical diagnosis. Lyme's been nationally reportable since 1991. That case definition got modified in 96, 2007, and again January 1st of this year. So this year they went from calling different Lyme states endemic or non-endemic to high incident and low incident. And so in states with a high incidence of Lyme disease, all you need is the EM rash, exposure to possible tick habitats, and that's enough to confirm Lyme disease. Now the high versus low incidence is based on a cutoff of 10 reported Lyme disease cases per 100,000. This number was chosen because it's a very straightforward number. It's clearly and conservatively defined for more than a decade that states having a high burden of Lyme all fall within the same 14 states. So nearly all high incidence states have a much, much higher than normal, higher than average number of Lyme cases every year. So here's the current CSTE case definition. For a confirmed case, we need a case of EM with exposure in a high incidence state, or a case of EM with exposure in a low incidence state plus laboratory evidence of disease, or any case with at least one late manifestation that has laboratory evidence. So those are confirmed. Now we turn to probable cases. They're any other case where a physician has diagnosed Lyme disease that has laboratory evidence of Lyme. And a suspect case is a case of EM where there's no known exposure or laboratory evidence, or perhaps a case of laboratory evidence but no clinical information is available. So the diagnosis is based on signs and symptoms, history of exposure to ticks, and laboratory tests. The lab tests are very useful if used correctly and performed by validated methods. They're not recommended if no symptoms of Lyme are around. And it's really important to correctly diagnose Lyme because we need to know, in order to know how to treat a patient, what they've got, and to not be treating patients that don't have Lyme. Let's find out what they actually have. So before we get into the details of testing, I want to show this little schematic on pretest probability. There's a lot of Lyme testing done in the U.S., and this is to remind us that the interpretation depends on the population being tested. So over here on the left side, we find a case where the disease is common. So if you have 100 people tested, you may have 60 that are positive and 1 false negative, or true negatives and 1 false negative. You could have 40 that are positive and just 1 false positive. So the percentages of false negatives and false positives are both very low where the disease is common. However, if you're in an area where it's rare and you have 100 people again, and if you have 97 that are negative, you probably won't have any false negatives. But if there are only 2 or 3 people positive, you could have 2 false positives, and that means that the positives are 67%. And it creates a difference in interpretation. We have to take into account where we're doing the testing. There's a Haiku for diagnostic testing that's quite lovely. Where disease is rare, positives mostly deceive, even with good tests. So here's our official listing of Lyme cases. And you can see we have not identified very many over the years. The definition changed again in 2007, so beginning in 2008, we haven't identified any until last year when we found 2 probable cases, and they fit the case definition for surveillance. So we're going to talk about the 2-tiered testing, and this is really what I want to get into in this presentation, is the appropriate way to test for Lyme. And these tests are not straightforward and always easy to interpret. So CDC recommends this 2-tiered testing. The first test is either an EIA, an enzyme immunoassay, or more rarely this IFA. Now, if this test is negative, we don't need to go any further. This is a screening test, and we don't do anything else. If the first test is positive or indeterminate, sometimes called equivocal, then we need to go on and do the second tier of testing. So this uses an immunoblot or Western blot test, and results are considered positive only if both the EIA and the immunoblot are positive. If symptoms are less than 30 days, we need to have both an IgM, which are antibodies that show up very quickly with disease, and an IgG. And the IgG antibodies show up later in disease. So if we have an EIA positive and an IgM positive, it means for the IgM to be positive, there are bands of different proteins that are identified, we need 2 of the 3 IgM bands to be positive. If it's more than 30 days, then it doesn't matter what the IgM is. What matters is if there's an IgG that's positive. And with this, we need 5 of the 10 bands. Now, there's quite a bit of cross-reactivity with these tests, and that's why we need to follow the definition appropriately. Many of us will show bands on the IgM, or IgG for that matter. There are many other spirochetes that we normally have in us that will cause these bands to be positive. I think almost all of us have some of these IgM and IgG bands. There are a number of alternate tests for Lyme disease, and our Lyme literate doctors and their patients who are looking for laboratory evidence of chronic Lyme disease generally are using these tests. Several are found to be not reliable at all, and one of the more common ones that's used is an IGeneX test, and this has not passed scrutiny by the FDA. There's another culture test that also is not accurate, so we don't recommend using these tests. There's a whole host of tests that aren't recommended. These are using assays that have not been established as being accurate, and this just lists some of the inaccurate tests or tests that we really can't depend on, including doing just the Western blot without having the EIA first. So we classify cases as a case if the medical provider specifically says this is not Lyme or this is a tick bite or an insect bite, we don't call it a case. We notify CDC of our confirmed and probable cases. So let's switch gears and talk about ticks and tick ecology a little bit. Ticks have 4 life stages: the egg, a 6-legged larvae that molts into an 8-legged nymph, and then the adult tick. They have to eat blood at every stage in order to survive, so they require blood to molt to the next stage. It can take up to 2 or 3 years for ticks to complete their life cycle. Many die before reproducing if they don't find a suitable host to feed on. They feed on all sorts of animals, on mammals, birds, reptiles, amphibians. I hope you can see these pictures to show how many ticks there are on some of these animals. There's very little ovarial transmission. In other words, the eggs don't carry over the disease from the adults, and so when they hatch into larvae, they're considered uninfected. Humans usually get Lyme from the nymph stage, so that's the stage that we're most concerned about with Lyme disease. Ticks find their hosts in kind of odd ways, but this may help us all to avoid tick bites. They don't fly or jump. They do what's called questing. They hold on to a leaf or grass or shrub with their lower legs, and the upper legs are outstretched, waiting to climb onto a passing host. They're looking for the heat, the carbon dioxide, whatever they're looking for, anything that brushes against them, they're going to grab on with the front legs and then find a suitable place to bite the host. Now, there's some evidence that I'll show you in a minute that that this may not occur, this questing behavior may not occur the same way in the South in the black-legged tick. So why is it so uncommon? Why is Lyme uncommon, even though we have the right tick here? Well, the black-legged tick, or Ixodes scapularis, typically have a 2-year life cycle. There's lots of other ticks in Arkansas, but this is the only one that causes Lyme disease. Now, it's called a deer tick because the adult prefers large mammals like deer, but they don't play a part in the transmission of Lyme except to move ticks around. So they move ticks from here to there. So the next few slides are going to show us the differences and studies that have documented this between northern and southern black-legged ticks. So in the north, the Ixodes scapularis feed primarily on little mice, white-footed mice, and other small, highly reservoir-competent mammals. But in the south, they frequently will feed on lizards, and the arrow is trying to point out the tick on this lizard. And they are very low reservoir competent for Borrelia burgdorferi. Another difference, and I find this one very, very interesting, is the host-seeking behavior is quite different in the north and the south. Normal tick drags, which is that white sheet that you see, they drag it over vegetation and then collect the ticks that grab onto it. And so the traditional way of collecting ticks gathers a lot of ticks in the north, and we're only talking about this one tick, the Ixodes scapularis. A lot of them are collected that way in the north, but when tick drags are done, very few are collected that way. So they did their test where the probability of observing the nymph stage questing on the top of a stem versus down in the leaf litter was much greater in the north than the south. One study showed it to be almost 20 times greater. Another didn't have the same huge results, but still a very big difference in the behavior. So ticks of the north are much more likely to ascend vegetation when seeking hosts. So ticks in the south stay down in the leaf litter more. And when they took southern ticks and took them up north and put them in a northern environment, they still remain down in the leaf litter. Northern ticks brought to the south did their questing, where they crawled up on the top of things. So their behavior, or host-seeking behavior, seems to be strongly determined by genetics rather than an environmental condition. Now, maybe this developed environmentally because we're hotter in the south and maybe they would desiccate or dry out more here. But at this point in time, it does appear that the questing behavior is very, very different. And these are peer-reviewed scientific articles that have determined this. So this just sums up some of the reasons why we feel we see much less Lyme in the south. In the north, this tick is frequently found on people, and it's rarely found on people in the south. It's collected by tick dragging in the north, but rarely in the south. In the north, the host, the primary host of the larvae is mice, whereas here it's lizard, and their questing behavior is very different. So I've included the references, and this makes a lot of sense. It actually, is quite feasible that those are the differences. So there are some issues with reporting of this two-tiered testing. For one, sometimes labs allow providers to just order the Western blot as a standalone test. And that's not considered a standalone test. So we can't always use those results. Similarly, sometimes just the EIA will be done, and we will get that lab report, and we'll never have a follow-up to it, because with some labs, they will, on a positive or equivocal EIA, they will reflexly then do the Western blot, and that result might come weeks or a month later. But if there's a negative on the second tier, we hear nothing. So we get these reports and then have to follow up on them. It matters what timing of the disease it is, and so we can't just go by the result without finding an onset date or clinical symptoms. And even if it's formed, some labs just don't follow up. We don't know what the next test is. So it's really important to look at these lab results in depth, and they're not straightforward or easy to interpret. This is just a picture of just one, but every lab reports them differently. And you can see they've listed out all the bands there, and they'll either call them non-reactive or reactive, or sometimes they'll call them positive and non-reactive. And you've got to look closely to see whether it's an IgG band or an IgM. The interpretation is not straightforward. Every lab reports them differently. Sometimes they will mix up the IgG and the IgM bands all in one column, and you have to sort through and figure out, okay, wait a minute, this is an IgM, not an IgG. So up here in the red, we see that because there are only 3 positive IgG bands, and we need 5, it's negative. And the same down for the IgM. No bands were positive, so it's negative. So Lyme surveillance in Arkansas. My wonderful epidemiologist, Richard Taffner, and I decided beginning in 2015 that we wanted to take a deeper look at all these lab reports that come in. And so Richard asked our folks to start saving both the electronic copies of these Lyme reports and the paper ones from partway into 2015 through 2016. And we had hundreds of papers. And we always intended to start this deeper surveillance, but competing interests and staff shortages, we never had time. Zika hit, and we were so busy with other things, we just never had time to do this in-depth look. And so we requested assistance from CDC with this high volume of tests. So they came in with this big stack of papers and began sorting and helping us figure out how to follow up. So they did a lot of sorting. We began with 911 laboratory reports from a year and maybe 3/4. They found that there were repeat ones, so they came up with almost 600 that were individual people rather than 911. Some of them were repeats. They found that almost half of them didn't have enough information to call them a case or not a case. 48% were definitely not cases. Then they found 11 that were suspect cases and 3 that were probable cases. They also found, which frankly we didn't, 2 confirmed cases. Now these were our confirmed cases, and these two both had travel history to high-incidence states. One of them was a person who lived in New Jersey or Connecticut or somewhere where Lyme is very prevalent and had just moved to Arkansas the week before. The other had spent months and months in the Northeast and again just happened to get sick while they were in Arkansas. So those two are travel-associated cases. The conclusions that the CDC folks came up with are these two confirmed cases, and locally acquired infections are rare or maybe don't occur at all in Arkansas, but they did confirm that we're still a low incidence state. Despite the high volume of tests received, with an in-depth look at these tests, we still find that we don't have a lot of cases in Arkansas. And perhaps this will help guide healthcare providers, reminding them to consider this diagnosis in patients with a history of travel and maybe look for something else if there hasn't been travel. The other thing CDC did for us is they helped us to prioritize what ones to follow up, because you can't follow up 400 or 500 in a year. It's not feasible. So we want to follow up on the ones that are most likely to be Lyme. So the recommendation for optimizing our processes are prioritize follow-up on case reports, both in the follow-up category or the not enough information. And frankly, we need to know in this process the disease onset, whether it was more than 30 days or less. When we get these lab reports, we rarely have the medical record. So that means we have to contact the provider and get the medical record to determine that. And then not all laboratories are created equal. So we have to have confidence in the reporting laboratory. Some of them use their own homebrew tests that are not approved by FDA. We need to enter these partial reports into a spreadsheet or a database so that if we get another report on that same individual, we can recognize it, because that second report may come in much, much later. We are going to update our case report form so that it will include fields specific for the two-tier testing and instructions on when to report. And they came up with a wonderful algorithm for us to prioritize cases for follow-up. And it's just a very simple, easy to understand algorithm. And here it is, their simple, easy to understand algorithm. It isn't as easy as it looks. But I'm just going to walk you through one little, area of it. But they've color-coded it so that, the reds are negative, the yellows are positive, greens we have to follow up. So if we get an EIA test, a screening test that's positive or equivocal, from there we have to use, we have to know whether it's a lab that always reflects to do the Western blot, and then we have to hold that for 30 days to see whether they're going to send us results of the Western blot. If we don't get results or they're negative, then that one is not a case. And you can see it's complicated. So here's recommendations for optimizing our external processes, not the ones within us, but externally, what can we do to make this work out better? So we need to communicate what we we as a state need to our commercial and reference laboratories. And there are many states that have this same problem, and I believe we're going to get a bunch of states to get together with us to request some of these larger labs, hold that EIA test and send all of the results at the same time, or send the negative results as well. Don't just leave us hanging. So that will help us with a great deal of the incomplete information. We'd like them to also not offer a single-tiered test because it's not useful. It doesn't help us. We can't diagnose it that way. And we want to provide targeted educational materials for our providers who often don't order the correct tests. They check a box that says tick screen, and whatever that box is on that lab is what gets tested. And we need to also inform the infection prevention nurses of the correct tests. And they did another easy-to-read schematic for our reporters and to know what to report and what not to report. So again, a very simple algorithm. Anybody can do it quickly, but it's complicated. We don't want to forget that we really want to prevent Lyme disease. So the way to prevent it is the way to prevent all tick-borne diseases using a tick repellent. DEET is one that works very, very well. You can treat your clothing with permethrin. You can buy clothing already impregnated with it, or you can buy the permethrin and treat your clothes. This will repel ticks from getting on you, and it survives through a number of washings. And the other thing is to do a thorough tick check as soon as you come inside. If we remove ticks promptly, they don't have time to transmit disease. So for Lyme disease, it's felt that they have to be attached at least 36 to 48 hours before disease transmission can occur. So the same with the diseases that are more prevalent in Arkansas, like the spotted fevers, Ehrlichia. Let's get the ticks off right away. So now the burning question, does Lyme occur in Arkansas? Well, it could occur here. It's certainly possible. We've got the right ticks. There have been studies that show that the ticks do carry Borrelia. It's widespread in our ticks, and so it's possible. We have the wild rodent reservoir here, that same white-footed mouse. Lots of Arkansas residents have been diagnosed with Lyme disease. Lots of them. Now, do they have Lyme disease or not? They don't always fit our algorithm. Our CDC review really confirms that we're a very low incidence state. But the flip side is, I don't think we should categorically state that Arkansas does not have Lyme. I think we need to look at it closely. In vet school, I was always taught that if you're not looking for a disease, you will never find it. If it's not in your differential diagnosis, you're never going to diagnose the disease. So I think rather than our providers categorically saying we don't have Lyme here, I think it would be more useful to do the appropriate testing in the appropriate order and explain the results to the person. To me, that makes a lot more sense. But maybe we have Lyme, maybe we don't. And I'm happy to entertain any questions. I don't know if you can read that, but it says, I understand you spent the whole summer on someone's rear end, and can you tell us what that was like? So, any questions? Yes, you have to be at the mic.
Hi, everyone. I'm one of those people who was denied testing in the state of Arkansas. It was a lot easier to look at me and say that I have severe anemia or liver failure or fibromyalgia. It took me 3 years. So after that, finally, I did get a doctor who was very well educated on some of the things that Dr. Weinstein is saying, and immediately diagnosed me with Lyme disease. Now, we didn't use a lab that was licensed within the state of Arkansas. It's an approved lab. They use PCR testing. It's been proven for years and years. But with the circular rashes that I had all over the back of my neck that I was initially told must be shingles that didn't hurt, but happened to look like bullseyes. I went to a free clinic and all that. A lot of free clinics don't have a lot of time to spend with people like me, but if they would have agreed to test and if the doctors would have been more educated from the very, very beginning, I wouldn't have this awful disease that's taking my life. I don't know how long I'm going to have to live. I have organs that are shutting down, but I'll go to my grave making sure that everyone here, in addition to what you have said, knows the truth and knows the research that's actually out there that's available, and knows that ever since the early 90s, consistently, there has been Lyme disease cases reported every single year in Arkansas. And Sue, I have copies of those, and I know you must have seen them. I know you must know about the study done in 1995 by the U.S. Army here. I hope you do. And
Yes,
in
ma'am.
1993, the study that was funded by the Arkansas Department of Health, done by a couple of individuals from Arkansas Children's Hospital, that also said that Arkansas is at a moderate to high risk for Lyme disease. And on behalf of a lot of people that are here that don't have the ability to stand up right now, I want to know how you feel about those studies and how come at one point Arkansas was stated by a lot of researchers as a high incidence state or at a high risk. Why all of a sudden are we not? And so that's my first question, respectfully. And my second question is the lizard thing. We have prairie lizards here, which are genetically different from the eastern or the western fence lizard. And I have been calling herpologists all over the state, all over the the eastern and the western coast, and I can't find anybody, no one even in the state of Arkansas that I spoke with knew about the protein that the lizards are supposed to carry. But there has not been any studies whatsoever on the prairie lizard, which is genetically different within the state. So I want to know if you guys know something that we don't. And I do know that when the CDC came, they had talked about putting in more money for awareness for this issue. At least that's what I heard you say in a report. I just wanted to know what, are there going to be any additional campaigns as far as prevention and awareness in Lyme disease?
So let me answer the second question first. I know of no lizard studies. I haven't looked for them. So no, I don't, although there is a documented one, and I've listed the reference in the thing. The third one is, the answer to that is the CDC has not given us additional monies. So I don't know where that came from, but I would love it if they would. We certainly will apply in the next grant cycle because that's what we do. A great deal of our ADH funding does come from CDC, and so we will be applying again for more funding. But currently, until the next grant cycle, we have what we have. The first question on the studies, both from the Air Force Base, and then I believe you may be referring to a study done by a graduate student up at UA Fayetteville. There are a number of references that many of our Lyme advocates keep going back to. The testing that was done in the 90s on these ticks was not necessarily as sophisticated as what can be done now. I don't think any of those reports, I've seen the Air Force one, they don't document in any way how they came to their conclusion. They just have come to a conclusion that their members may be at risk here. However, I will tell you, because we work very nicely with our Air Force Base, that the folks there now don't consider Arkansas a big risk for Lyme. So it's tricky. It's tricky. I want to say
testing was a lot of out of date, you know, in the 90s and everything. And
Yeah.
realized that. But the IDSA actually is still going. They haven't changed their research in years. Method with steer that was developed. Was it about 30 years ago?
honestly, I don't know. But let me,
No, it was 30 years ago. And
yeah, let me
the
say
same
one other thing.
method as well.
Uh-huh.
But in the military documents, they do have exactly what methods they use, how they preserve the tick.
Yeah.
Maybe you don't have that version, but I can.
No, I just have the results. But let me say one other thing, too, if I may. I think people like you, and there are many in our state that feel that they have Lyme and it's been missed. I think y'all do have something. I think it's real. I don't think this is all in everybody's head. It could be potentially possible that there's another disease out there that we have not yet diagnosed.
Tick that was in my bed.
Yeah, but
I'm
not specifically referring to you.
In Nido, which is one of the most renowned,
Yeah.
the most sophisticated equipment you can get.
If I
in the
can
entire-
finish 1 second. If I could finish. I'm not specifically referring to you. I'm referring to many people in our state, and really throughout the South. Arkansas is not the only state with this same issue, which is why CDC wanted to come in and help us with this. I still personally think there's an opportunity or a possibility that there is something else that we have not been able to identify yet. Heartland disease is new. Bourbon disease is new. There are new things being diagnosed all the time, and I'm actually hopeful that further research will show things. I'm going to ask Dr. Smith to answer.
strains of Borrelia that
Right.
are known here in our commercial.
And maybe
medicine
there's
lab.
another one. Right. So, Dr. Smith, sure, thank you.
Sue, thank you very much for an excellent talk.
Uh-huh.
As Director of the Health Department, I'm very proud of the work that we have done here. Arkansas has a huge burden of tick-borne diseases. Although we're a low-incidence state for Lyme, we have a tremendous burden of many tick-borne diseases, and the expertise that we've been able to develop here and also partner with our federal counterparts of the CDC, I think has really provided data that is helpful, useful for clinicians to understand what is known, what is not known, and also to guide clinical practice in terms of the types of testing algorithms that are likely to come up with accurate diagnoses and the information that they need on an ongoing basis. Now, putting on my hat as a clinical infectious disease physician, this is really important stuff. This is where public health meets clinical practice and ultimately is there for the benefit of patients. Our mission is to protect and improve the health and well-being of all Arkansans, and I think this is where our data can be very useful for clinicians. And as an infectious disease physician, you know, I've seen and treated people with Lyme disease who acquired it in higher burden states. I've also seen patients who presented with signs and symptoms that weren't typical for Lyme disease, were tested with tests that are not standard, and then treated with treatment algorithms that are not recommended by professional bodies, and most of them just didn't get better. And it's hard for me to think that we got the right diagnosis there. So it's really important for people who have illness that they get the right diagnosis, that they get the right treatment. Otherwise, they generally don't get better.
Thank you. I appreciate that, and I fully agree. I mean, I think these folks have something.
Joe Thompson, I want to thank you for your presentation. I also want to thank you for being here today, because I've got a family member and we have this conversation and it's not easy. I guess a question, I just want to go, I think the challenge is to make sure that we are all, as public health or as clinical folks, inquiring into what we could be missing and where it could be leading us into either a new disease or a better test or whatever. My question is, on your Western blots, you said that you had to have 5 bands positive, I think, if I remember correctly, for it to count as a positive test.
For the IgG.
On the IgG.
2 of 3 on the IgM.
And the example you showed had some positives, but it didn't make that threshold of a positive score. Now you have 10 bands, and the threshold is there. Is there any pattern when you don't make the threshold that could lead us to think there is another spirochete or another infectious agent out there that we're partially detecting but not accurately detecting? False positive, or when you have a positive band but it doesn't make the threshold, I guess my question is there any pattern in those negative findings?
There seems to be on the, and let me start by saying I'm not an expert, a laboratory expert on the bands, but at least on the IgM, when we get 2 of the 3 positive, which is actually quite common, it does seem to be the same 2. Now, I don't know if that pattern is the same for the IgG, where you need 5 of 10. From what I've seen, but I haven't actually studied it, it seems to be all over the board, and it can be any one of them. A lot of times we don't get the IgM. For example, on the 2 cases that we called positive probable last year, we wanted to get follow-up blood work because we had the less than 30 days for the IgM and had 2 or 3 bands positive. So it would have been very helpful to have gotten a follow-up lab work after the 30 days to see if there was the 5 of 10 bands on the IgG, but we were not able to get that. And that's the case on many of them, where all we can do is call it a probable because we don't have the ability to get that follow-up IgG. Thank you for your question. Thank you.